and I've been fortunate enough to know for quite a few years. I think our presentation today is just going to be really well received. And we partner with Family Care Center very closely. They have multiple agencies around the state of Colorado, and I believe even are going into a couple other states as well. So I'll let Dr. Yaw talk about that a little later on, but just an incredible agency to work with, great clinical care for individual therapy, med management, TMS, and we're just very fortunate to have Dr. Yaw with us today. So as we get things going, just a couple of housekeeping items. There is going to be a Q&A box that'll open up in about 10 minutes. So if at any time you do have a question for Dr. Yaw or the presentation, feel free to plug it into that Q&A box. I'll be monitoring that. We will parking lot a few things if the timing just isn't a great point to jump in, but we will get to your question as soon as possible in that chat, in that Q&A. So please know that if you don't hear your question or get an answer to your question, feel free to plug it back in there towards the end. We'll leave a few minutes for that at the end as well. Just one more note about Peakview. The military population here in Colorado Springs is very vast, and we have a lot of veterans, active duty, and dependents in our community. And at Peakview, we're fortunate enough to serve an entire program of IOP and PHP active duty members. So if you know of anybody that is needing or seeking services around the Colorado area, we're very happy to help. Our parent company is Summit Behavioral Health. We have multiple psych facilities as well as substance use primary facilities nationwide. And so at the end of this, if you're like, hey, I want to learn more about what you all do, what your company's about, please don't hesitate to send Janice or I an email, and we'll be happy to discuss, what we offer. But with that said, I'll let Dr. Yaw take it away. Today's presentation is working with military families and their unique behavioral health needs. So Dr. Yaw, it's all you.
Okay, good morning or good afternoon, depending where you're at. I really am very glad to talk on this, speak on this topic, and I really appreciate you joining me today. So this is very dear to me. Just telling a little bit about myself. I spent 22 years in the Army as a psychologist. My discipline is a clinical psychologist, and over the years have really seen the behavioral health needs for our active duty and their families, and really see a very strong need even to this day as we continue. And so what I wanted to do is just kind of share a lot of my observations and some of the trends I've seen most recently, but also share with you a lot of the data that we're getting from the past decade and more about where we really need to focus our efforts in providing the best care for military families. What I also want to do today is provide some insight into the unique needs for military families. And there's often a sort of unmet needs that we find with military families that we wouldn't think about firsthand as being an issue. And we see some of our families struggling with those sort of adjustments. And so I'll speak a little more about that. And finally, what I want to do is just offer some recommendations how to really get involved and how to connect military families to services, and in making sure that we're getting the best quality care for those who serve and their families. A little bit about myself. As I mentioned, spent 22 years in the Army, retired last year, actually. So I'm still pretty fresh from leaving. My last duty assignment was Brooke Army Medical Center, where I was the department chief there, and had been the department chief at Fort Carson as well, plus other jobs that I've worked in. But I've worked across the board in both care delivery, and also working in policy, and working at the ground level within units, and deploying with 4th Infantry Division. So I kind of come to this today with wanting to share all of those experiences and some of the lessons learned that I found as a psychologist, as a clinician myself, and kind of bring all those things together. And hopefully that will provide some new information for those of you that want to work with these families. So first off, what I want to do is just go over our agenda here. The agenda we have today is really kind of going over these 5 learning objectives, and as I mentioned before, kind of talk more about the trends and the data from the past decade, But then I want to get into some of the more subjective areas in terms of what it's really like to serve for these military families, and talk about what a typical military family life is for families, and what sort of challenges that they have. Identifying the primary reasons for behavioral health referrals. Oftentimes, we don't see, all the referrals don't necessarily match up with them being in the military community. But I wanted to kind of give you an idea of what we're seeing, both on the internal side from internal referrals within military treatment facilities, but also what we're seeing out in the community where I'm at now. And then we're going to identify reintegration challenges for redeployed service members, and then also talk about how the community can really foster resilient military families. Right now, I'm serving as the regional director at Family Care Center in Colorado Springs, and my responsibilities are for the clinics that we have here in Colorado Springs. And it's a really critical, for me, it was a really rewarding and very critical position. And I'm very lucky and happy to be in this position because we have a very large military community here in Colorado Springs, as Eric mentioned, several military bases and a large community here. So I hope to share personal experiences that we are seeing here in Colorado Springs, and things that were more national across the board, and in the Army on the active duty side as well. Okay, so moving forward, I'm going to be sharing quite a bit of data and statistics, and I think it's good for us to get a good sense of what we have out there, and what the latest data that's been gathered concerning military families. There's been a lot of interest in how we are providing care for our service members and their families. So there's been many different organizations and government offices that have actually looked at this over the years, and really are trying to find, first of all, are we providing quality care? Are we providing access to that care? And how many families are actually not seeking care, and what are the reasons behind that? So those are some of the large areas that we look at. The data that I'm going to be reporting is from several different resources. There's an annual Department of Defense demographics report that kind of gives us a yearly look at what is our military composed of. How many active duty, how many families, what are the age groups, what are their backgrounds, and we get that an annual report, and that really helps us for planning. Really thinking what do the services need to provide in terms of family care, and how many active duty we are going to be providing care for. So that's a very important data to look at on an annual basis. Another one is from the Defense Manpower Data Center, which really focuses much more on the active duty side. SAMHS really looking at some of our substance abuse challenges across the board, and what our statistics are in that area. And there's been a focus on the military from this organization to take some data and look at that as well. Then also there's non-government organizations such as the National Child Trauma Stress Network, American Homefront Project, which does a lot of work in this area, National Military Family Association, and a lot of scholarly articles written about providing care for military families. What are the challenges? What's the access that we have? And what are some of the unique areas? So I'm going to be combining all of that with my own personal experience as well, to hopefully give a kind of a well-rounded picture of what we have and the challenges we have. So first of all, what I wanted to first of all present, most of the focus here is on families, of course. So starting off, wanted to provide this statistics. We have in 2018, so it's been a few years ago, but the 2018 statistic, we had 2.1 million military personnel. And that number has gone down over the years, over the past 4 years or so. And now, but out of that 2.1 million, we are seeing about 40% of that population are parents. So we do have a lot of military children across the military. Kind of give you an estimate of what we have. I don't have the exact number of how many beneficiaries or children we have for active duty, because that number is always changing. But this gives you kind of a good picture about how many we have out there that are family members that we need to care for. And so overall, what we have seen from the most recent years, especially since operations kicked off in Iraq and Afghanistan, and even earlier to Desert Storm, is we've seen a very strong demand for behavioral health services. Initially, when we're seeing this, like even by the Desert Storm times in the 90s, it really started off as a very slow trickle for those seeking care. Perhaps a lot of reasons for that, that there's still a lot of stigma associated with seeking care. And that affected our military members, where we've, all the services have taken a lot of action to really reduce that stigma and really provide increased access. And then also, as the years built across the board, from Iraq to Afghanistan, all the years that we've been at war has been adding more and more to the stress for military families, and also for the active duty members as well. And so we've seen the demand for behavioral services grow dramatically. From my time in the Army, from the 22 years, really started off very much more slower. And by the time I went out, leaving my position there in San Antonio, saw a large number of family members that were really challenged to receive care in the community. And that is where all of you come in, because I think there's such a strong need and demand, many different ways that we can go in and support as a behavioral health community. One of the things I want to talk about now too is access. As I mentioned, just getting the access to those places. One of the big challenges we have is that our military bases nationally, we have many of them that are in very remote locations. And, we're not all having, for example, Brooke Army Medical Center in the middle of a very large metropolitan area, many more resources than an Air Force base in North Dakota, for example. And so some of our smaller military treatment facilities where they might have some behavioral health, access there, they're very limited in what they can provide at those locations. So they're experiencing a real high demand, but very limited ability to provide all the care that's necessary. A lot of these places too are really having to really rely on the community. And what we call it in the military is we call it purchase care. And that is when, the Department of Defense and our Defense Health Agency is literally saying, we're going to purchase healthcare for our beneficiaries in the community. We're going to work with our managed care partners and managed care contract to go across the board and make sure that we're getting the right kind of providers on board and making sure there's enough available. So there's been a constant shift really to push more and more to the community, given the demand. So the military treatment facilities have not been able to keep up with that demand. Of course, what we're trying to do is prioritize the active duty and the active duty family. But there's many situations where we're even having to send our active duty to the community as well. And so hopefully that's giving you a picture of where the demand is, whether you're in Colorado, Texas, or Washington State. Very similar experience across the board. I've got an alarming statistic here that really like to see change, but of all of our active duty service members, one study found only 60%, let me reverse that, 60% did not receive care. So only 40% actually went and accessed care. So there's a lot of, within that number, there's a lot of things. Some never sought care, actually, said that they wanted care, but they never followed through and sought care for whatever reason, for stigma, for access, some of those things. And then some of them, unfortunately, are in a position where they really just cannot get in and cannot get that appointment at the place they want to receive services. So that is a very alarming number when you think about the many years that we've been at war, our nation has been at war, and the number of of families that have been exposed to these frequent deployments and separation, and not to mention our service members experiencing trauma in combat, a lot of places. So unfortunately, we have a very large unmet need out there. So what I want to move to next here is kind of discussion of what we're seeing in terms of the diagnoses. And I'm going to cover this a little bit later as well, but we're seeing quite a few different diagnoses, and I'm going to talk about the more common ones. But I believe we have a question right now. Maybe I can answer that.
Yeah, Dr. Yeaw. Caroline asked, how is mental health care affected for those families who live overseas, especially where bases are smaller?
Very, very good question. And that really depends, because we do have better capabilities at military treatment facilities at some of our overseas locations. For example, in Germany and Korea, Japan, that we actually do have some pretty good availability there. It still is a challenge, especially for family members trying to get in, because they would most of the time would need to go to the local economy, and you really hope that you can provide an English-speaking provider to receive that care. One of the things we've done to remedy and really address that concern is been utilizing telehealth, and that has seen a very, very large rise, especially in the COVID pandemic, utilizing telehealth as a way to access care. But you're really hitting on a point. Our overseas families really have a challenge there of trying to seek care.
Thank you for that answer. We have one more question. I'm not sure if it fits in right here, so we may need a parking lot it, but Adam mentions, I've heard a lot of issues within the VA system. Is this as big of an issue as the news portrays? And if so, why? I'm not sure that may tie in directly with active duty and their family members, but if you feel like you want to take that one on, feel free.
Absolutely, I can comment on that. Most of my experience, what I'm presenting today, of course, is really focused a lot on the active duty families, and I certainly can throw in the Guard and Reserve as a part of that. And the reason I focus that more is because of my experience. I wanted to interlace a lot of my own personal experiences across the years. But in terms of the VA, absolutely, the VA is feeling the same strain. And we here at Family Care Center are actually seeing quite a few folks that were enrolled at the VA and were seeking care. So we've partnered with the VA here in Colorado Springs to try to supplement their ability to provide care. But yeah, they're absolutely experiencing the same sort of demand and the nationwide shortage of behavioral health providers, especially in certain type of specialties. Okay, so we're going to get through the data first, and I have a few more for you here. What we had found is from the years 2016 to 2020, there's been nearly 500,000 active component service members diagnosed with at least one mental health disorder. Of those numbers, over 84,000 were family-related problems. So that is quite a number. You think 500,000 of our active component service members have been diagnosed with at least one mental health disorder. And so that gives you a real big perspective, especially when you think about how many of them actually receive care. And I mentioned before, one study found only 60% had received care. So that's very concerning. The most common diagnoses we're seeing across the board are adjustment disorders. And I don't think that's a surprise for most folks on this call, is that given the adjustments of military families having to move, the deployments, the op tempo going up and down, we're seeing a lot of adjustment disorders. The number two most common diagnosed was relationship problems, and that's kind of tied with combat trauma. So we're seeing like both of those actually very interrelated as well. So we're seeing those relationship problems, and that's broad. It could be a family problem and seeking family therapy. It could also be a parent-child problem that we're seeing, but across the board, these relationship problems. And then I will mention one important area is marital therapy and couples experiencing many challenges, particularly newly married couples. We have very young people in the military that get married young and face a very large stressor, such as going on a deployment and separation for a year. And by the way, having two small children at home, it gives you an idea the tremendous amount of stress that we see there. So we're seeing relationship problems as a big factor. And then finally, to round out the top three, we're seeing a lot of depression and anxiety. Actually, some of these adjustment disorders turning into major depressive disorders and episodes and anxiety disorders, in addition to PTSD, of course. And so those are the main areas that we're really seeing that we need to provide our most services. Pause 1 second there. I believe another question has come.
Yeah, Shauna asked, are these diagnoses given during military service or post?
Great question. Actually, most of these diagnoses are given officially while they're on active duty. So it's in the official record. So the numbers I'm reporting are diagnoses that were made, officially in that service member's medical record. However, there are a portion of those that were diagnosed before they came into the military. And so it's very hard to chase down that number because we are seeing a lot of people with prior behavioral health histories that we're not seeing that until later in time, perhaps a year or two in. And really to get that number of how many there are is a real challenge, because even if we get some estimate, it's probably going to be underestimated for that part. My personal experiences across the years, I've seen many different soldiers that had quite an extensive behavioral health history even before they came on active duty. And unfortunately, those weren't reported or they were minimized. And so we're finding, that we have soldiers that have these conditions we really need to treat.
We had a couple follow-ups as well. One of them was, what was the number one diagnosis?
The number one diagnosis is adjustment disorders, but just broadly of all type of adjustment disorders.
And then another question, it's quite a bit, so I'm going to read it slowly to you. Majority of this covers active duty. However, will there be more Guard, Reserve, and veterans in the future heading to significant mental health crises? So majority of active duty do not seek care because of the rate of discharge for self-reporting. Could DoD utilize LPC, MFT, et cetera, on their staffing to prevent disorders from occurring due to deployment, such as workplace toxicity, military sexual trauma? So kind of a couple questions in there regarding Guard, Reserve, and veterans and the increase in mental health crises. And could the DoD utilize, I think, other licensures to start supporting some of this?
Sure. When I was on active duty, one of the things that I worked with the director of psychological health for the reserve, the national director for the reserve, and also had many connections with Guard directors of psychological health over the years. And my big concern goes for those soldiers that are in those components, because they often go back home without the same access to care, the same resources that are available to the active component. And that has been a very, very big concern. And we've seen many that, in the Guard and Reserve, they're actually put on orders to stay on active duty so that they can receive care at the installation. But yeah, that has always been a challenge, particularly in more remote rural areas, again, where that has been a big concern. And prior to the COVID pandemic, there was a lot of red tape in terms of delivering telehealth care across state lines. And that kind of held up us providing more care. But since then, a lot of states have, first of all, the COVID pandemic allowed that to be very flexible. And then secondly, a lot of states are joining these interstate pacts for licensure. So you can provide telehealth services into a different state. So I'm very glad you mentioned that. Although my talk is focused on active component, the Guard and the Reserve, in my opinion, faces a much bigger challenges in the sense of accessing those same resources that we're afforded on the active component side. In terms of getting a larger workforce in place to support, this real rise in behavioral health demand. Absolutely. It had been sometime within the past 5 years or so, there was a period of time where I was working at the Office of the Surgeon General, and we were looking very closely at getting licensed professional counselors, LPCs, as part of our behavioral health workforce, and being able to allow that licensure. And we finally got there on the Army side. When I left active duty last year, it wasn't quite completed in the other services, but now we're under the Defense Health Agency. They're looking at standardizing that. So yes, all mid-level providers, LPCs, LCSWs, LMFTs, we certainly need all. It's an all effort. Everybody needs to just come in and join. Here we have psychiatric PAs, psychiatric nurse practitioners. We have psychiatrists, psychologists, social workers, LPCs, LMFTs. We have the whole gamut. And for the longest time, there haven't been many, psychiatric PAs within our ranks. And so we are seeing that on the increase as well, which is good news. So it's happening both on the civilian sector and also on the active duty and active component as well. Okay, almost done with the statistics. Just a few more to throw at you. From 2016 to 2020, we had 27,000 mental health visits for family problems, and it increased every year from 4,554 in 2016 to 6,607 for the active component. So they really took that subset of the active component and were able to see how much that's increased for family problems during those years. And so just as I mentioned, that's right at the heels of the pandemic, but starting back in 2016, it's still at the end of our Afghanistan participation in Afghanistan operations. So that's kind of what we're seeing, gives you some more idea. And then one thing we saw during the past 5 years, I'm just focused now on the COVID pandemic, because that was something that, again, really impacted access to care and access for services. During the past 5 years, there were decreased visits, mainly due to the COVID pandemic during those years. But the suicides in the active component was increasing 10% from 2019 to 2020. And so, based on where you're at and what sort of services provided, most people that were providing behavioral services switched to telehealth. But on the active component of the military treatment facility, we had a lot of challenges in terms of getting our staff out there to provide services. And I switched a lot of our providers to telehealth very immediately, but we needed to always maintain that ready access for crisis and walk-in services and inpatient. And so that was one thing that really kept some of our soldiers from seeking care, because of some locations closed and some not knowing that they can come in as a walk-in and getting the word out so that those are the most crisis can come in and seek care. So hopefully that gives you a picture of what we're seeing, just over the past decade, pretty much, about what we're seeing for families and active duty seeking care. So unfortunately, it's not a very rosy picture. There's a very high demand, an increase in diagnoses, and unfortunately, we're seeing an increase in suicides and more difficult to get access in some areas. So, hate to paint a gloomy picture, but I think out of this data and information, we as a behavioral health community can really strategize and find how can we provide the care for our military families. So I'm going to move to our next area of topic and just quickly go over the typical military family life. What we have is, a lot of people on this call is very familiar. We probably have a lot of military on this call and prior service. But for those that are not familiar, just make sure everybody's tracking what a typical military family life looks like. One of the things, first off, is just the pace of the military family life. Oftentimes, it feels very rushed for these families. On average, most families are moving every 3 years with their service member. And it takes probably a good year to get settled and get into a new school system and develop a social support system in the community. And then the second year, probably doing a lot better. And then when you get to the third year, you're already starting to think about your next assignment and how you're going to manage moving your entire household, how the spouse will get a job, how their kids are adjusting to the move. And so the 3-year period really is a very shortened period of time that families have in order to adjust, to all these changes. There are frequent PCS moves, permanent change of station moves. And, it's different from each service for the most part, but in general, it's about 3 years for most. Then you have all the stressors from deployment. What we have in the military is we do have what's called the deployment cycle. And so there's many different phases, both operational things that the military does with the service members, but also within that life cycle, what sort of things we're doing and managing with our family. Things such as, okay, well, we know that there's going to be a deployment within the next year. So there's going to be a 60, 90-day train up, and that's going to take them away from their family during that time, pre-deployment training. Then there's all of the other readiness things, the medical readiness and getting the family all the appointments they need, getting things settled before, the service member leaves. And, that's another thing. And as I mentioned, during that cycle, we're going to see all these other things coming up, such as, okay, how we're going to get our kids in school, how are we going to manage that if as a single working parent now, how am I going to take care of that? And then the big thing is if it's in a combat zone, how is the family coping with that fear and stress, that your loved one is in a combat zone and in danger, and so we're seeing a lot of those things. Oftentimes there's a lot of financial stress associated with this, because sometimes it does result in the service member's partner having to quit their job, to be able to manage the household. And those sorts of things that are typical roles that a spouse or partner might normally not do, such as paying all the bills or managing the household, might not be their normal sort of thing they manage, but now guess what, they have that as well. And so many different opportunities for stress there. And those are just to name a few of the stressors. But before I finish the others, I'm going to pause for a question.
Yeah, so Michael asked, I've heard that the increased suicide risk for people in the military is the same for both combat roles and non-combat roles. Has there been research that explains the suicide risk factors that are specific to a military group, since combat may not be a shared factor for both groups, such as grief or unrootedness? Any information on combat versus non-combat suicide risk?
Yes, you're absolutely right. There was a study in the past that actually found was quite surprising, actually, because they were looking at linking, with the suicides, completed suicides, really looking at what was that linked to? Was that linked to those who had deployed and had been exposed to combat, or were these home front issues? And surprisingly, one study found that it actually was not linked to a deployment. If they were frequent back-to-back deployments, there was a link there with potential increased suicide risk. And out of that, though, what they found, though, is that many studies found that they were pretty much equivalent. Some that were suicides that were done back home versus some that were done in theater, and some that were single soldiers, and some that were within the family or a broken family. So what, in summary of all of that, what we're finding is that it really is factorial when you look at it. There's many, kind of like what I'm showing on this slide, many different factors involved. We have soldiers that have come through combat trauma and have pretty severe PTSD. They return home and their PTSD is impacting the relationship with their partner and their kids, and that creates stress. They're seeking therapy. The soldier might start drinking, and now we have an alcohol problem. So it's very compounded. And for those who have never deployed in a combat zone, we are seeing suicide risk there as well, because overall the stress of the military life, there are very high stress jobs that are home front as well. And we don't want to make the mistake of just focusing on those active duty service members that deployed to a combat zone, because we're going to miss a large segment of this population and providing services. So hopefully that kind of answers that question there. Okay, so covering all these things, I'm just going to sum up this slide. One thing I really want to emphasize is the stress from the unpredictability. We are built where we want to have routine and predictability, particularly for our kids. Children, our younger children have a very hard time understanding many different changes. Has a very big impact on young children because they don't have a predictable world. They don't have that stability. They don't have mom or dad there the whole time. And they don't quite understand what it means to deploy or to be away. And so there's a lot of stress from that unpredictability in young children. And we're seeing it also in, the adults in the relationship that, anything can change. And from all branches, you can never expect anything to really go through until you actually get your orders. And even then, your orders can be canceled or changed. So you really don't have much control over your life and about where you're going to go and where you're going to live and what type of job you'll do. So that creates like a big challenge for our families, is just that unpredictability. And then so some of the risk factors that we're seeing that I'm kind of mentioning, that I mentioned up here, what they have really contributed is that they're seeing that school-age military children actually scored higher on emotional behavioral problems at 2.5 times higher than the national norms. So our military children are really at particular risk for all of these things that are going on with their active duty parent that is serving. So so really one of the things that I would like to have everyone think about is understanding that it's really multifactorial, and you as behavioral health providers can see there's many different approaches to trying to help families with these different areas. I mean, much more beyond stress and anxiety, but then you have concerns with attachment and reattachment, forming social circles, and you're seeing substance abuse problems. There's many different things that we're seeing here as a challenge. So I'll pause right there for another question.
Yeah, Dr. Yeaw. So Danny mentioned many people enlist in the military may have pre-existing childhood trauma that could even be a contributing factor for why they join the military.
Yes.
And often they don't escape that trauma and then have additional trauma from the military. How is that taken into consideration, I think, is the question.
Yeah, definitely. We are seeing that quite a bit. We're finding many studies have supported that there's a higher risk for PTSD of those having a childhood trauma, even if they were never diagnosed with PTSD prior to the military. We are seeing that very commonly in our soldiers that have had verbal, emotional, physical abuse, neglect, those sort of childhood homes, growing up in foster care, many of those challenges, and really kind of predispose a lot of them to risk of a major illness, PTSD or major depression or anxiety disorders. We are also at times sometimes seeing some of our soldiers with personality disorders that really, that from a childhood that they grew up in has been like a real challenge to really function and perform well in the military with those things. So the goal of all military providers is really our goal, and what we do every day is really to conserve the fighting strength, which means keeping our active duty members ready, to really fight America's wars, and be available for that. And so, the challenge again is having some of these soldiers with really complex histories of things that really predispose them to these illnesses. And what we do is we provide, the best evidence-based care we can. We make sure that it's readily available to them. that, we don't overlook that. We address it immediately. We work with commanders and units to emphasize the importance of getting, their soldiers the help that they need. And we're seeing a lot of them that are returned to duty and that actually, build a lot of resilience, or they had resilience going through this, and are able to make it through their deployment and their enlistment. But absolutely, it's good that you point that out. We do see a good number actually that had prior behavioral health treatment.
Couple more questions that popped up as well. Heidi asked or mentioned the 2.5 times higher incidence in school-age children is very noteworthy and significant. Are there any other studies or places to read more about that statistic?
Yeah, I kind of mentioned some of those data sources that that update some of those things, but what we're seeing a lot, I would kind of turn you towards the academic side, towards the literature that's out there, because there has been a lot of studies that are pulling data from different places. So, just for me to get kind of updated for today's brief, I wanted to look at what we had out there that was potentially updated, and I'm seeing quite a bit that's been published for the past decade in this area, and really focused on that. So that's probably what I turn you to. But there are also publicly available reports that are out there, as I mentioned before, that do talk about military families. Some of the non-government ones are the ones that are independently gathering that data, such as American Homefront Project and National Military Family Association, just to name a couple there. So those sources are pretty good to look at. And don't be surprised though if you find discrepancies in the number, because it's a very large problem and very many different ways that this is being measured and documented.
One other question. Cheryl mentioned, I have a large military family, several kids in multiple branches, all enlisted. One thing I've always wondered is why don't they do better at getting the military families better integrated to form a network of support among the wives or husbands of the military members? Do you think this could help with the mental health aspects, especially the stress and anxiety? Is anybody looking into that concept? And then Cheryl mentions the officers do a much better job at this.
Yeah, absolutely. You're spot on there. We have in many locations, we have family readiness groups. In fact, on the Army side, they're required. These are groups where family members can actually meet and socialize and form those social bonds. It's not mandatory, and you're absolutely right that it seems to happen more with the officer side. We have we do have some other options too. We do have other events and different things, even MWR sorts of events that provide the opportunity for families to interact and meet. But there's nothing directed. There's nothing to say you will. It's going to be a matter of each of the services really having a good strategy to bring families together at certain events. And from my experience, there are some bases and installations that are actually better at it than others. And then some of the very, very large bases and installations like Fort Hood, for example, it's much, much more harder, to manage that and be able to get these groups in. But we need to do better in that area. You're spot on there. Okay, I already went over through this, our primary referral reasons. We're going to see a lot of adjustment disorders, both on the service member side and the family member side. We'll see a lot of those. And then not surprisingly, a lot of these really persist and they turn into depressive and anxiety disorders. I did mention the family problems. We have all kinds we're seeing. We're seeing parent-child problems. We're seeing couples. We're seeing a lot of this going on where a lot of these challenges are, communication, conflict resolution with the family, a lot of just general disruption and being able to, form bonds for reintegration. When soldiers come home, it really changes everything, when that service member returns. So we're seeing a lot of family problems out there, and then learning and school problems. You can imagine, you have a 7-year-old, his parent or her parent got on a plane and they'll be gone for a year. You can imagine what that 7-year-old is thinking and what they're going through, and what it's like having a single parent home or living with grandma. So a lot of these sort of things interfere with learning problems and school problems, and sometimes it gets chalked up to ADHD, but many times it is boils down to anxiety and adjustment. And so you're going to see a lot of those. The schools such as like here in Colorado Springs that are close to these installations, they're seeing a lot of these kind of problems. And we've been doing a lot of outreach from the military bases to the local school districts to provide that support for this particular challenge. Um, Okay, getting close to wrapping this up, but what I wanted to do was talk about some of the reintegration problems. I did talk a little bit about that, but before I go into that, I can answer another question.
Yeah, one of them, I think it was kind of relevant to what we were discussing. I was going to parking lot it, but the question is, I apologize, let me scroll down. Is there any kind of, I guess, implementation or attention to active duty persons' parents and the challenges that they may face to deployment? Just curious if there's resources or if there's any, I think general attention to what parents may face when their young people deploy.
Not that I know of. I know that locally, some military communities have these sort of events and groups that form, and even whether it's even a chat group online or support groups form locally, but not of any national effort that I know of. Some of these other organizations I named, that's like their purpose is really to try to get that out there for the other family members, because it affects everyone. Especially you have a young 19-year-old unmarried that's deploying, and just had been living at home with mom and dad. They're going to be going through a lot of these same stressors. So not anything standardized or systematic across nationally that I'm aware of, but many organizations and local communities have put these in place.
One more question that popped up. This is a bit of a loaded question. I imagine we could have our own continuing education event on this topic alone. How does gender impact these challenges? And can you speak more to the military culture in terms of gender?
Okay. That's a very good question. I definitely oftentimes see different problems that, whether male or female soldiers that are coming in for care, definitely have seen more of a gender split. In general, those of us like myself, when I was on active duty, that was actually within a unit, within a brigade, and providing services as a deployed soldier myself. Obviously we're predominantly male in the Army. There's a larger number of males in the Army than any other service. And when it's in a cultural setting like that, where I am part of their unit, wearing the same patch as them, I was able to see males come in for care. If we're doing it right, if we've already set up a good outreach, we're working with the chaplain and commanders, and we're seeing that. Stateside, however, is a little bit of a different story. What I've noticed more frequently is I'm actually seeing more women being more willing to kind of seek care at the military treatment facility than males. And a lot of reasons. One easy guess for that is just the stigma that's attached to that. And there's also, besides the behavioral health stigma seeking care, there's also the gender stigma, I would say too, that if you're a male soldier, you shouldn't need to go talk to somebody. You should suck it up. You should drive on. So that's another thing that in my personal experience I've seen. One final thing I would note is a lot of the females I'd seen, which is very disturbing, but a lot of the females I've seen over the years were victims of military sexual trauma. And that's happening much more frequently than we recognize, and that we may recognize, I should say. But we're getting our women soldiers back, survived combat zone in Afghanistan, only to be sexually assaulted by another soldier, and it's a giant concern. And the good thing is that we do have good programs in place for those women to receive, really get some confidential care that provides all their physical, medical care, and really quickly gets them into behavioral health care. So those are just a few I'd probably name, but certainly I would say certainly gender plays a role in many of these areas. Okay, so just to summarize with the reintegration problems, one of the big things we're seeing is we are seeing when a service member returns home, often they're the unwelcome family member. You think the whole family would, be happy. There's a honeymoon period, dad's home, mom's home now. But then as soon as mom or dad start getting into the family routines and cook something for dinner, or doesn't do doesn't go outside for a walk like they normally do, that creates a problem, because it's now like, okay, well, now you're changing our family routines, which is very important because that's how the family is coped in that time. The other thing is sharing responsibilities. Sometimes the spouse of the deployed service member has got it down pat after a year about the best way to manage the household, and doesn't need the spouse to come home and just redo all of that, and it creates resentment and conflict. So those are one of the areas that we often see coming back. For children of all ages, I would say even couples, you're seeing the attachment and separation challenges. I mean, just like you'll see developmentally, you'll see, some of this like anxious attachment when a parent comes back, and oftentimes rejection altogether. You left me and I'm leaving you and I'm pushing you away, which is really heartbreaking for a lot of the service members come home to, expecting to come home to open warm arms, and then they feel this rejection from their family. And that is just simply a part of the nature of what these deployments do and how that impacts the family. And then, of course, I mentioned PTSD and substance abuse are very, very high. In some units, you could almost say that they're rampant. They're occurring so frequently. Okay, so my final slide, here's where I really want to kind of infuse hope in this conversation. We know what the problem is. We know the high demand and lack of availability. There's many, many different ways to contribute. One thing that we're seeing out there is that there's a lot of community resources, particularly in a military town that has an installation in their town. They're out there, and you'll see them out there, plus military service organizations that are there just to support, even if it's the USO and others that are there to just support these families and the reintegration process. What we could do as behavioral health providers is really help our families build relationships and develop a community support system. Oftentimes they're not going to be doing that automatically, because there is a sense that we're going to be moving soon, so why bother building a relationship or joining a church or things like that. So that's one area that we can really help them do, is make sure that they have a good support system in place there. Research shows the importance of evaluating both stressors and resources when we assess youth from military families. So really be sure that we're looking at the challenges and the stressors we're having, but balance that with providing a good assessment of the resources, and be the subject matter expert on that, and be able to share that with your families. There's another thing too, if you're a behavioral health provider, some of you may have heard of this. It's called Give an Hour, and these are behavioral health providers that provide services, really pro bono services in military communities and underserved areas. And here in Colorado Springs, NAMI is very large in supporting the military. So also look at NAMI and some other additional organizations. So in summary, thank you for having me here, because I really like to be able to share my personal experiences and share the data with other professionals about the real need that we have for the military families. Although we're not having a major war right now, we're back from Afghanistan, understand that these are long-lasting effects that still impact in our families, and we really need to be there to support them. And there's many ways you can support. So with that, I will turn it back over to Eric if there's any other last questions.
We do. We have a few and a few that I parking lotted as well. So I will kind of drum through these. Adam asked, do you believe there is still a stigma in regards to mental health treatment within the military? I think we all know that answer is yes, but if you want to expand a little on what that stigma might look like within the military.
Yes, definitely. And the way it looks like, I would say it depends on the type of unit, the type of job you do. If you're working with a security clearance, there's a very, very big concern there. That's a very common concern that, or you're a pilot, very concerned about seeking care because you could lose your clearance, lose your career. So it really depends on where you're at. But I can say after 22 years, it has improved a little bit. So over the years, I've seen some gradual improvement, and so that's really good news. And I'm glad to be able to report that.
This question kind of ties into the security clearance that you mentioned. Someone shared that their brother was a veteran and lost his security clearance indefinitely after having to be TDO due to a manic episode. It's my understanding that once security clearance is taken away for service-related mental health issues, then it's impossible to reinstate. This causes people to lose their jobs, not able to find a job on the experience and qualifications. Have you ever worked with anyone who has this type of experience? And have you heard about possible progress or solutions to work toward allowing for reevaluation of clearance?
Yes, I've come across that a few times, that their clearance was flagged, so it wasn't removed yet. But what we do is on the military side, we do security evaluations, and so we get asked by commanders, is this person capable of safeguarding secrets, and sensitive information, and we have to determine that based on the severity of their illness, obviously whether they're psychotic or had psychotic episodes when they're manic, if there's any history of suicide, substance abuse, some of those things that a lot of us would think about would impact your reliability in those areas. So it's not, it really feels like a stigma, like, okay, well, you're a mental person, so you don't have a clearance anymore. But it goes a lot further than that. I mean, we do have an opportunity to evaluate that and provide recommendations up. Now, we as behavioral providers aren't the final say in that, but there is an ability to have that re-examined and looked at. And I've had some individuals and pilots that, for example, that wanted to get their rep slip to be able to fly again. And we have evaluated, and I've had circumstances where after an evaluation determined out of my recommendation just to return them back to flight status. And I've never seen that commanders go the opposite way. They usually will take that. So at least there's a common sense way of addressing that, through a behavioral health provider.
Yeah, thank you for answering that. Just one quick note, Janice put it in the chat, but as people do log out, because we are hitting time, we understand, but we will go through a few more questions before we log off. As you log off, you will be taken to an evaluation link. Please fill out that link. We'll also be emailing it out. Knowing how our presentation went and how you felt about the topic really helps us guide these in the future. So if you wouldn't mind filling that out for us, we greatly appreciate it. As we jump back into some of the questions, this one was brought on quite early, but I wanted to save it till the end just because, I don't know if you would have these statistics in front of you, but what about the rate of infidelity and divorce currently, and what are the main contributors to these issues? Is that any kind of data that you would know about as far as infidelity and divorce rates?
I could speak for my time years ago. I mean, this was back in 2006, but I was tracking that closely as the brigade psychologist in the 4th Infantry Division. And because we're having high rates of divorce, I was actually doing some marriage enrichment sort of things, with the soldiers, even in Iraq, doing some of these marriage enrichment and marital communication skills sort of things. At that time, the estimated rate for 4th Infantry Division was 40%, which is really sizable. And that again, that was the estimate. And what I was finding that a lot of that was from is they're often very rushed weddings before deployment. So we get a lot of young people that rush in and say, let's get married. So you have benefits back home. You know, a lot of young kids not even thinking about it and getting married quickly. So that's what I saw quite a bit. And the other one I saw is just the distance and the feeling of growing apart due to the time away. And the service member that's deployed builds their own community there in theater. So it's almost like they're in their own new relationship there, and the spouse is back home in their own relationship, and they really get the sense that they're growing apart. And so that's why communication and helping them maintain that intimacy from a distance is something that really should be focused on.
Yeah, yeah, I agree completely. This question is in regard more to veterans, but do you think more veterans seek services through the VA or private providers?
Oh, I think I'm going to say it has just to depend where they're located, what sort of VA services, where they live. Um, you know, I personally am hearing stories of some veterans that are coming here at the Family Care Center for care that I'm treating, that are telling me that it's very, very hard to get in to the VA. Not to badmouth the VA because they're outstanding here. They're a partner with us. But the volume, as I mentioned, is overwhelming. And so we partnered with the VA to be able to bring them in. I do think they prefer in the civilian sector that they're given more ready access. They're given appointments pretty readily, and they're getting care pretty immediately. Most of the time we get people in within 1 week. Sometimes a couple of days later we can get them in. So we have like some good availability for providing care. I would speak as a veteran myself. I would speak as I would just go to whoever could provide care for me first, you know, and good care for me first, you know. And so all things being equal, whoever can get me in the soonest, that's where I'd want to go.
All right. And then another question that kind of falls in line a little more on the TRICARE side, but my group is the only TRICARE provider within 90 minutes. Is there anything being done that you're aware of to increase the number of TRICARE providers by addressing the reasons for low numbers of providers?
Yes, very glad to get that question because in 2024, TRICARE is going to, the TRICARE contract is going to different managed care contracts. So TRICARE dollars are basically, they're things that were built into TRICARE that required much more availability of services, much more transparency of access and how to receive those and those care, more transparency about building those panels. So if you're a TRICARE provider on Humana or HealthNet, it is their responsibility to make sure they have a real active, provider panel that they can provide services. So there's a lot of built-in things with the new TRICARE contract coming out, and that's going to be in 2024. Probably the biggest change in many years, and so I think that's going to make a big difference here in accessing care and getting more TRICARE providers online, and hopefully, potentially, actually better reimbursement rates for TRICARE.
Yeah, absolutely. I don't think anybody, especially in Colorado, will complain about more TRICARE providers. That's for sure. One question is related to schools. So from the school system perspective, there is a stigma of military parents allowing students to see outside therapy. I'm not sure if it's officers only that are worried that it might affect their officer status, but are there organizations that support military families' mental health support without it being reported to their superiors? I know that's certainly a challenging question. I have heard personally from schools in our own district that young people tell their school counselors that they're fearful of seeking services because they don't want it to impact their parents' ability to rank up and things like that. And I believe, Dr. Yeaw, I've heard it's just concern for overall readiness. So, right, if that military member's readiness could be impacted by family, but I'll let you kind of dive into that.
Yeah, that's a good question. I mean, I think first of all, I think that sometimes that's just a perception, like if you were to go case by case, and look at that. I mean, in my experience, the only ones where it impacted, you could say impacted somebody's careers when that child was enrolled in the exceptional family member program, and they needed to have that continued care, otherwise they could decompensate or need to be rehospitalized. And so usually mainly severe circumstances like that, where we're seeing that could have an impact. But I've never, in my 22 years, I've ever seen a case where a child receiving care, the active duty parent, anything happened with their career or their movement or any of those things, because it's confidential. It doesn't get reported up. If they're receiving care in the sector, or even if they're receiving care at the military treatment facility, it doesn't go to the commander. Oh, the so-and-so kid is being seen. It's still confidential care. The final thing I'd say about that is we have school-based programs now here in Colorado Springs. It's great. It's a part. They work for the military treatment facility here at Fort Carson, but they are counselors that are actually in the schools themselves and are able to do a lot of prevention and direct care, and really reduces the impact on the parent having to pick their kid up and taking them to appointments, because everything is right there. And military families have loved that, because they know their kid is being seen and receiving care, and it doesn't impact their work.
Yep, great answer. I think that falls right into line with the stigma. Sometimes it's just a misperception of the actual facts that are out there. I know we've seen that often here at Peakview too.
Right.
The last question pertains more specifically to El Paso County. Could you speak to what you know about the El Paso County postvention suicide research and outreach with a goal of informing our suicide prevention programs? So I think, how can, just your expertise in the general military population be a part of the El Paso County postvention suicide research and outreach to really inform future suicide prevention?
Yeah, I definitely think Family Care Center, we look for opportunities like that where we could partner with the community and work with the different school districts here in Colorado Springs and El Paso County. I think there's many ways we can do that, and first of all, just being a healthcare provider, being able to provide those services when we've identified. I mean, I know you're talking about postvention, but some more on the preventative side, having ready access on the postvention side. Absolutely. I mean, a lot of those family members and the impact on them really need services afterwards. But there are some more immediate, postvention sort of things that are done that that I'm aware of. So I haven't even been back in Colorado Springs for a year, so I'm not as familiar with some of those efforts, but I definitely think it's a good opportunity for possibly for Family Care Center to partner.
Absolutely. I think we're getting to the end with everybody. I do have a couple more questions. Patty, you asked for a contact to see if I can have someone at our school. I believe you're referring to the MFLACs, Military Family Life Counselors. I will look for a good point of contact for the MFLACs and see if I can send that on. I don't think Dr. Yeaw has that at the ready, and I don't as well, but I will find that information and send that on to you, Patty. So I'm going to make a note with your name right now. With that, I think, Brian, you said you're an MFLAC. Military One Source connects people with MFLAC. So it sounds like Military One Source might be a good starting point, actually. So thank you all for chiming in on the chat. I appreciate that. Just to be mindful of our time and Dr. Yeaw's time, it is 12:10. So I appreciate everybody who held on this long. We had over 200 attendees today. So thank you so much, Dr. Yeaw and Dr. Yeaw and Family Care Center for providing that excellent training and just your time. I mean, I think especially any military heavy community, this is a topic that could go on for hours, to be honest, with a lot of questions for folks. So we hope to hold more of these in the future. Peakview does host a CE event about once a month. We have a couple more events coming up. Some are local and in person. Others will be virtual for the state of Colorado. And in the future, we'll likely have some national ones as well. I'm going to let Dr. Yeaw take the last couple seconds to chat a little bit about Family Care Center and their services, just so you all know you have a good resource in them as well, with folks who are very familiar with the military population and what they do.
At the Family Care Center, we provide outpatient behavioral health services. As I mentioned, we have a wide range of providers. We do medication management, psychotherapy, We do TMS is one of our big specialties. We are the leader in providing TMS in the state of Colorado. And we have clinics across the Colorado Springs area that's under my region, both on the north side, south side, east and west. You know, we even have a clinic up in Woodland Park, up north by Interquest and by Mark Shuffle, Parkmore Village, which is kind of by Academy and the mid part of Academy, North Academy. And then we have Circle, a large location here at off Circle Drive. So we provide a wide range of services. You know, we have good access for folks to get in. And, you know, and just in summary, I really appreciate the invitation to speak. And, you know, thank you everybody for listening to me for over an hour.
Sounds good, Dr. Yeaw. Well, again, from Peak View, from Summit, from Family Care Center, just a huge thank you for this. We'll certainly be in touch. I'll go ahead and let you sign off today. And folks, you have my email address. If you have other questions, concerns, need a point of contact for Family Care Center, happy to provide that. Again, they're a fantastic partner for your private therapy and medication needs. All right, Dr. Yeaw, thanks so much. Take care today.
Okay, you too.